Yes.
Hello,
Yes, sir.
can you see my slides?
Yes,
And
sir.
can you hear me?
Yes.
Okay, I'll start my talk today. So it is about thyroid ophthalmopathy with ocular myasthenia. And we see these patients individually, thyroid ophthalmopathy patient and ocular myasthenia patient. But sometimes it can happen together, and it's very important to pick up the combination from therapeutic point of view. So the case which I'm going to present today is a 50-year-old gentleman who had a COVID infection. And 1 month after this, he presented to the neurology clinic with history of protuberance of the right eyeball. 15 days after the onset of proptosis on the right side, he noticed partial drooping of the left eyelid. There is no history of double vision, but there is history of diurnal variation of the left side ptosis. There is no history of limb weakness. There is no history of dysphagia. He was evaluated for this unusual clinical presentation. He was clinically diagnosed as right side thyroid eye disease and ocular myasthenia presenting as left side partial ptosis. So this is the photograph of the patient. You can see there is a proptosis in the right eye. There is a staring look. And the left eye, you can see the eyeball looks prominent, but there is a partial drooping of the left eyelid. In fact, he complained to me that my right eye looks bigger, my left eye, the eyelid is drooping. Sometimes it droops more than what you can see in the picture. So the MR of the brain and MRI of the orbit, you can see there is thickened ocular muscles on both sides. And it is reported as enlarged ocular muscle, extraocular muscles on both sides. And this is another cut, you can see there is a enlargement of the ocular muscles. The thyroid function test showed evidence of hyperthyroidism. Free T3 and free T4 levels are increased, and TSH was below 0.01. TPO antibody level was 20 international units per ml. Serum acetylcholine receptor antibody level was 12.6. X-ray test was normal because we do X-ray test usually to make sure any thymus enlargement is there or not. So the X-ray test was normal. MRI orbit showed enlarged bilateral extraocular muscles. The patient was treated with miomercazole, oral steroid, and pyridostigmine. So he had his hyperthyroidism got controlled, and the steroid helped him for both ocular myasthenia as well as for the hyperthyroidism induced ophthalmopathy. And the pyridostigmine made the ptosis to disappear. He recovered well. Simple combination, he done extremely well. So the conclusion was post-COVID and para-COVID autoimmune disorders are well known, because I have seen myself quite a lot of autoimmune disorders in COVID time, and even now I see neuromyelitis optica, patient getting thrombus disorder, and Guillain-Barré syndrome, CIDP-like picture, and I have collections of myasthenia, para-COVID, during COVID, para-COVID, and post-COVID myasthenia. I have collections of myasthenia patients. So I think everyone would have seen like me. So it's post-COVID and para-COVID autoimmune disorders are well known. This is an unusual case of thyroid eye disease and ocular myasthenia in a patient during the immediate post-COVID period. So he has done well with the appropriate treatment. So it not necessarily should happen only because of COVID. There are a lot of literature which I will tell you in the coming slides that this combination is known in a normal autoimmune background. This is another patient I saw with, you can see it's a quite enlarged, angry-looking eyes, sticky eyeballs, and you can see that it's a quite severe thyroid ophthalmopathy. And he was treated with steroid and IV methylprednisolone he had, and he had hyperthyroidism. He has done well. I think they have been thinking about orbital radiation and rituximab and all. Luckily, he come out, and but he had some partial ptosis on the left side, and which subsequently his antibody level was high, acetylcholine receptor antibody. I think it was around 20, and he done well with only pyridostigmine. I not put him on any azacitidine or anything. He done well with pyridostigmine itself. So this is another case of thyroid orbitopathy with ocular myasthenia. So if it comes to the theoretical part, the Graves orbitopathy, autoimmune disease of the retroocular tissues occurs in 20 to 25% of patients with Graves disease. The main autoantigen is TSH receptor, expressed primarily in the thyroid, but also in the adipocytes and fibroblasts. Very, very important because it's also expressed in the adipocytes, fibroblasts, which is the main pathogenic mechanism for the enlargement of the retroorbital structures. The TSH receptor and activated T cells plays an important role by activating the retroocular fibroblast and adipocytes. The volume of both extraocular muscles and retroocular connective and adipose tissue is increased due to the inflammation and accumulation of the hydrophilic glycosaminoglycans. The risk factors are, some people are prone for this. It's not necessarily a female-specific disorder. Both patients are male patients actually. So not necessarily should happen only in the female. The incidence is more in the female population. So genetics, female sex, smoking, and prior radioiodine therapy are some of the factors that makes the people to get thyroid orbitopathy. Approximately 10% of patients, Graves' thyroid disease is absent. Orbitopathy happens before the onset of hyperthyroidism in 20% of the patients. You don't need to have hyperthyroidism by investigations or clinically, but the orbitopathy happens before that in 20% of the patients. It happens together simultaneously in 40% of patients. 6 months after the diagnosis in 20% of patients. So 20 plus 40, 60 plus 20, 80, and 10% the Graves' thyroid disease is absent. Then it happens as a purely thyroid orbitopathy. But after the treatment for Graves' hyperthyroidism, in the remainder, commonly after the radioactive iodine therapy, they have hypothyroidism, then they have the thyroid orbitopathy. So 10% patients after the RAI therapy, 40 together, and 20% after the 6 months after the diagnosis, 20% before the diagnosis. So you can see all these combinations in the clinical practice. The clinical analysis of thyroid-associated ophthalmopathy with myasthenia gravis, there was a study, they documented 12 patients in Ongji et al. In 2015. When ptosis and eye movement disorders were not consistent with thyroid-associated ophthalmopathy severity, myasthenia should be considered. Whenever you see an unusual clinical presentation, that's why as I was telling that there's a partial drooping, and on one side there is a prominent eyeball, or maybe the ocular movement are not improving in spite of the proptosis resolved, we should consider associated ocular myasthenia. Histopathologic study of extraocular muscles in thyroid-associated ophthalmopathy coexisting with ocular myasthenia gravis. There was one study they had, it was a beautiful study, and they went for a orbital decompression in a case of thyroid orbitopathy. While doing decompression, they taken a small piece of enlarged muscle, they put it to the electron microscope, and they documented the electron microscopic picture of the muscle. It's a case report by Ricky Ma et al. 2020 BMC Ophthalmology Journal. The typical ocular myasthenia gravis changes were observed in thyroid-associated ophthalmopathy and ocular myasthenia gravis samples. Changes include central nuclei, aggregation of mitochondria, and fiber type grouping. This is a established, documented case of ocular myasthenia findings in a biopsied orbital, the extraocular muscle, in a case who present initially as a thyroid-associated ophthalmopathy. Progressive bilateral ophthalmoparesis, a case of simultaneous autoimmunity balancing Graves' ophthalmoparesis and ocular myasthenia. It is an interesting article you can read by Kanapa C. et al. In BMG case report in 2016. Extraocular muscles have fundamentally distinct properties that make them selectively vulnerable to certain disorders. This is an article by CYU Voyman et al. It's a review article in neuromuscular disorders in 2005. So we see sometimes that purely extraocular muscles are involved. The skeletal muscles are spared actually, and their extraocular muscles are not same like a skeletal muscle. They're different from the skeletal muscles. Skeletal muscles perform specific limited roles. They have specific roles. Extraocular muscles have to be responsible for a wider dynamic range. It has a special properties. Extraocular muscles, they are more dynamic than the skeletal muscles. Extraocular muscles fundamentally have a distinct structural, functional, biochemical, and immunological properties compared to other skeletal muscles. Eye fatigue resistance and the rapid, precise control of extraocular motility might explain why extraocular muscles are selectively involved in certain disorders such as CPEO, myasthenia gravis, and Graves' ophthalmopathy. So sometimes we see, like motor neuron disorders, the ocular muscles are spared. Some disorder, the ocular muscle involved and skeletal muscles are spared. is because they're not exactly the same muscles. Actually, they are different functionally, structurally, metabolically. Acetylcholine receptor antibodies in patients with Graves' ophthalmopathy in Journal of Neuro-Ophthalmology in 1995. They studied 50 patients, Graves' ophthalmopathy patient, and they found 4 out of 50 patients had positive antibody. That is, 8% had elevated acetylcholine binding antibodies. None of them developed signs of myasthenia gravis over a follow-up period of 4.5 years. So you have to keep in mind, when you do this antibody, when the patients don't have any evidence of myasthenia, ocular myasthenia, if you see a positive antibody, you don't need to get surprised. Sometimes this antibody can be elevated in patients with thyroid ophthalmopathy, and you should clinically correlate whether there's any clinical. Otherwise, we don't do routinely to all thyroid ophthalmopathy patient acetylcholine receptor antibody. Only if we suspect that we'll do it. But if we do accidentally these antibodies, we see some positivity with no signs of myasthenia, it can happen. Mild clinical expression of myasthenia gravis associated with the autoimmune thyroid disorders in Journal of Clinical Endocrinology Metabolism 1997 by Marino et al. Whatever patients I have seen, I think I have seen so far 6 patients. All the patients had only ocular myasthenia, and they had not had a very bad ocular myasthenia. They never had any serious type of ocular myasthenia. When I treated them with pyridostigmine and controlled thyroid ophthalmopathy, all of them done extremely well. So it is a mild clinical expression, and they are going into the generalized myasthenia gravis. Is not that common. If you see only pure ocular myasthenia, it can very well control with the specific medication. Myasthenia gravis associated with the autoimmune thyroid disorders as a mild clinical expression with preferential ocular involvement and lower frequency of thymic disease and acetylcholine receptor antibody. So you may see a very borderline elevation of antibody, and there is no thymoma, and they have preferential ocular involvement, not necessarily they have generalized myasthenia. Very commonly you see mild ocular myasthenia in combination with autoimmune thyroid disorder. So basically what I'm telling from this presentation is, whenever you see a thyroid ophthalmopathy, when there are unusual clinical findings, not explainable by the only thyroid ophthalmopathy, or the patient has some ptosis or some findings of clinical suspicion of myasthenia, always look for the combination of a thyroid ophthalmopathy with ocular myasthenia and treat them together. They do extremely well. Thank you very much.
Thank you, sir.
So I finished my talk.
Thank you, sir, for your interesting case. Am I audible?
Yes, you are audible, Dr. Miller.
Thank you, sir, for your interesting case. Any question from the audience?
I just